My name is Corinne Peek-Asa. I am the Vice Chancellor for Research, and I'm joined by my friend and colleague, John Crothers, our 1 week in UC Vice Chancellor for Health Sciences. So on behalf of Chancellor Pradeep Khosla, who is a very big fan of this program, I'm so pleased to welcome all of you to the La Jolla campus to participate in our winter symposium, Emerging Infectious Diseases, Are We Prepared? And you know the answer to that better than most people. We're looking forward to today's program and exploring the very real and continuing issues that microbial threats pose. We are seeing emerging infectious diseases on the priority list of the public, of legislators, and many of them don't know that there is a core of experts that have been leading thinking about this field for a very long time. We are living in a pandemic age, as you are also very well aware. We're a 3-year anniversary now into COVID-19 and still going through the learning process, the aftermath, the ongoing infections, figuring out how that impacts our science, our social life, our political life. But we're still also looking at all the things on the horizon. HIV, monkeypox, swine flu, dengue, West Nile, and Zika in just our recent history. And also, are you all probably very well aware, so many more on the horizon. Some are going to be based on our new environment, and we also have to be aware that some of them might be man-made and combinations of those. So as our human populations grow, as our world and society becomes more complex, we will have more animal to human and environmental epigenetic shifts and interactions that are the perfect world for emerging infectious diseases. As regional and international trade and integration intensify, infectious pathogens will not only hitch along, but they will meet and change and mingle much more quickly than our species can keep up with them. As climate changes, viral and bacterial vector-borne diseases will expand. They will hitch on to new regions. They will make historic returns, especially if we are unprepared. If we drop what we know works for infectious diseases, we already have a good playbook for. And it's clear that our future will be marked by the diseases that affect us environmentally, politically, and socially. So what exactly are emerging infectious diseases? Well, they're the ones that are newly recognized in a population. It might be well-known dengue fever in one area, but we're starting to see it pop up in areas that have never seen it before, partly because of social and political change, partly because of climate change. They are rapidly increasing in incidence and geographic range. Their speed is influenced by things we study: host susceptibility, ease of transmission, microbial adaptation, their own processes of evolving, but also social factors, things such as healthcare access, antibiotic resistance, the unavailability of vaccines, decreasing vaccine coverage, and our cultural views about vaccines and how those impact with health access and health equity. Persistent social inequities will be a huge piece of how we prepare. So working together will never be more important. Waning public health interventions, poor health messaging. So we need to work with our colleagues who understand marketing, communications, et cetera. So because emerging and re-emerging infections are deliberately possible, they're difficult to predict, let alone manage. We need to work together. We need to be nimbler. We need to have more partners internally and externally. We have limited resources. We will continue to have limited resources. So we need to make wise investments in the people, in the technology, in the healthcare infrastructure, the public health infrastructure, both for the people and for the research pieces, and translating those in a more effective way. We need to foster interdisciplinary science, and this puts UC San Diego and our partners in a really good stead because we are good at that. We can just take a poll of the different areas represented in this room to see that we are a mecca of interdisciplinary thinking and innovative thinking. Our public and private partners are also important. We never, ever have needed to listen to our community partners as much as we do now. We have never had to work with our industry partners and make sure we continue to lead the way as an innovation campus to have a path forward. predictive modeling, enhanced surveillance, laboratory discoveries, novel diagnostics, epidemiology, translation, communication, business, policy. There are so many areas that are needed to help us solve this problem. We need to train the next generations of scholars in a different way. We need to train them so they understand the science, but they also have to understand the translation. And we are already at the forefront in our STEM programs, in our health programs, in our humanities programs, in our business programs, in making that shift to creating tomorrow's thought leaders. And we have to make sure that embracing the whole trajectory of science from the very basic and very foundational, which was essential for our COVID response, all the way to the translational work is done in a way that we engage the community, that we hear what problems need to be solved, why they're not working in the community, and that we reintegrate that into how we are solving the problem. So groups that gather together like this one are exactly the promise of working into this new future. So with that, I am really delighted to invite John Carruthers up to talk a little bit more about what we'll do today to help us be prepared.
Well, good afternoon, everyone. And it's great to be back. As Corey said, it's day 5 for me. And having been here before, it's great to be back on the campus. So my name is John Carruthers. I'm the new Vice Chancellor for Health Sciences. I want to welcome you all to this wonderful symposium. UC San Diego is already on the right preparedness path. As Corey outlined, the university is globally recognized as a hub of multidisciplinary research and innovation, and in our own health sciences, we are mobilizing our basic, our translational, our clinical research, and our clinical care teams against emerging infectious diseases threats. Before and during the current pandemic, UC San Diego Health has been an essential local resource, a proven patient care leader, and an advocate for clinical trials, preventive medicine, specifically through vaccinations, and public health education. The School of Medicine has a long history and deep expertise in infectious disease investigation and treatment. Having established one of the first and largest centers for excellence in HIV, and I remember that center being here long before even I started here back in 1995. The Division of Infectious Diseases and Global Public Health is heavily invested in the fight against pandemics, and with its faculty providing frontline clinical care or leading numerous investigations and clinical trials to understand and halt the spread of various pathogens of concern. Indeed, today's Winter Symposium that you're all here celebrating partners themselves as further evidence of the university's effort to help secure a healthier, more proactive future. In 2019, a few years ago, UC San Diego founded its own public health school, the Herbert Wytham School of Public Health and Human Longevity Science, and that year also saw the establishment of the Collaborative to Halt Antibiotic-Resistant Microbes, or CHARM. In 2021, Chancellor Khosla gave direct support to create the Pandemic Response to Emerging Pathogens, Antimicrobial Resistance and Equity Institute, or PREPARE, a UC San Diego-based multi-institutional partnership that seeks to anticipate and mitigate potential infectious diseases threats before their devastating health impacts are felt. And in 2022, just this past year, we welcome Resilience, an NSF-funded Predictive Intelligence for Pandemic Prevention Center, which is creating a shared cyber infrastructure, simulation space, and pandemic intelligence management and collaboration environment to support community resilience to pandemics. So broad efforts. We learned a lot from COVID-19. All of us did. And that experience and how we respond is important. The delays to response give a novel viral outbreak the space to become a life-threatening pandemic is not acceptable for our future. This is not the situation we want to repeat. And as you can see, we are mission focused to combat emerging infectious diseases threats and understanding that many challenges will lie ahead as we figure that out. As Corey mentioned, leveraging collaborative science for the public good is something we are deeply dedicated to, and is why today's symposium is extremely important. We are grateful to your attendance today. Thank you so much for your attention. And now I would like to welcome Dean Cheryl Anderson of the Herbert Wytham School of Public Health to the stage to introduce our esteemed speaker, Tom Frieden. Thank you, Dr. Anderson.
Good afternoon, everyone. It is a pleasure to be with you this afternoon and to have the opportunity to welcome and introduce our keynote speaker, Dr. Tom Frieden. Now, when I got up this morning, like many of you, I was happy to see the sunshine, right? It's been a rough couple of weeks for us here in San Diego. But I had a little extra excitement because I have such a tremendous amount of respect for our keynote speaker today. And the fact that I get to be in this place with you and have the opportunity to tell you more about him and hear from him really was just a great way to start the day. So let me tell you about Dr. Tom Frieden. He's a physician trained in internal medicine, infectious diseases, public health, and epidemiology. He's the former director of the U.S. Centers for Disease Control and Prevention and the former commissioner of the New York City Health Department. As a public health practitioner, we always look to the New York City Health Department to see what's going on and what's going to happen next. And so that's no small feat. Dr. Frieden is currently president and CEO of Resolve to Save Lives. He began his public health career in New York City, confronting the largest outbreak of multi-drug resistant tuberculosis to occur in the U.S. He was then assigned to India on loan from the Centers for Disease Control, where he helped to scale up a program for effective TB diagnosis, treatment, and monitoring. He was then asked to return to New York City to become Mayor Mike Bloomberg's health commissioner. He directed efforts to reduce smoking and other leading causes of death that increased the life expectancy in New York City by 3 years. As director of the U.S. CDC, Dr. Frieden oversaw the work that helped end the 2014 West Africa Ebola epidemic, and he now leads Resolve to Save Lives, and in this effort, works with countries to prevent 100 million deaths and to make the world safer from epidemics. Now, that's a reason to get up in the morning, right? When he was working with the COVID pandemic, Dr. Frieden has overseen the expansion of Resolve to Save Lives, and their activities, they include policy and program innovations in the U.S. They counsel multilateral institutions. They support rapid response, ensure that there's healthcare worker safety and data-driven decision-making in more than 20 countries. Now, in case, he's not busy enough, he's been well awarded and has had numerous honors. And he currently now also serves as the Senior Fellow for Global Health at the Council on Foreign Relations. So Dr. Frieden, we're really excited to have you with us today. Thank you so much for joining us virtually.
Thank you very much, Cheryl. It's great to be with you, at least virtually, and I look forward to the conversation. And what I'll do is take us through some slides and talk a bit about where we are in the pandemic, what the implications are globally, nationally, and locally. And then I look forward to the conversation and discussion. Cheryl was kind enough to mention my work in tuberculosis starting in New York City. I thought I would start with that because in some ways, this outbreak demonstrated many, if not all, of the key challenges that we have in public health and infectious disease control. I was an epidemic intelligence service officer in 1990, posted to New York City, and it was an alert clinician who called up and said, I think we have a lot of MDR, multi-drug resistant tuberculosis. I led a very large citywide survey that showed that was the case. That led to very large increases in funding for control of multi-drug resistant tuberculosis. And ultimately, we found that the resurgence in tuberculosis in New York City was driven by really 5 different things. And often you'll find that an outbreak happens not because of one problem, but because of a series of problems. And one of the challenges was that there was HIV. This is before highly active antiretroviral treatment. It was a horrible time. I did my infectious disease training in the, or my medical training and infectious disease training before heart as an infectious disease specialist. It was a terrible time where we desperately wanted to help our patients, and we had very little to offer other than treatment of pneumocystis and some of the other conditions. But the result of that was that there was a very large number of people who were highly immunosuppressed in New York City, many of them in hospitals. Now, that would not have caused an outbreak of tuberculosis. Tuberculosis does not spontaneously generate. What the second key was a failure of tuberculosis control. The tuberculosis control program had really lost sight of what was important. It was no longer ensuring that patients were completing their treatment. It wasn't making the patients the center of care, ensuring that patients were the VIPs of programs. The social conditions were very challenging, including mass homelessness, mass incarceration, poverty, institutional spread, particularly in hospitals. We documented, based on actually the first ever community molecular epidemiologic study done, that most of the multi-drug resistant tuberculosis had been picked up in hospitals. And there were some hospitals that had very large outbreaks. Nosocomial transmission is a major issue and has been an issue with COVID, where nurses and doctors around the world lost their lives because of infections that they got in the hospital. And then immigration from high prevalence countries. There's a lot of TB around the world. And if we don't control a condition all over the place, it's potentially a risk all over the place. And that's the case whether it's monkeypox or polio or TB. And so I think in many ways, these factors, underlying health conditions, the failure of public health, social conditions, institutional spread in hospitals especially, and the cross-border spread of disease and cross-border travel, these are constants that drive much of the emerging infectious disease framework. Now, I will say that in those days, there was one strain of thought that said, you know, this is all a reflection of society's failures. And your attempt to treat TB is misguided, because what we need is a healthier society. We need to address homelessness and mass incarceration. We need to address the basics of our society. And I wrote a editorial for the American Journal of Public Health, basically saying, yes and yes, we need to address the underlying causes of ill health, but we also need to implement the programs that can save lives today. And those aren't in conflict. In fact, it would be unethical not to do both of those. So this is what happened. This is funding as U.S. cases declined. Basically, spending on TB control declined, and it increased again only when TB cases increased. And this reminds me of a sad, but I'm afraid accurate quotation by John Duffy, who wrote a wonderful history of public health in New York City. It may not be a bestseller, but it's an interesting book. He wrote, "Encountering apathy, ignorance, and avarice is the lot of all conscientious health officers. As preventive measures in the health area are more successful, the public is less inclined to support the programs which ensure this success." Now, in public health, if you succeed, the people whose lives you save won't know you've saved their lives. If you fail, you may well end up on the nightly news. Bill Foege, who led the global eradication of smallpox, has said that public health is a great field. You won't make much money and nobody's going to thank you. But if you can go get over those two things, it's a great place to work. But we found in New York City that rapid control was possible. When we started the TB control activities, we were able to improve the quality of diagnosis, treatment observation and supervision, and improve infection control in hospitals. And that led to a very rapid decline that served as a national and global model. This is the decline in deaths from tuberculosis. MDR-TB declined just as fast. All cases declined a little bit more slowly. But part of the reason cases could decline so quickly was an epidemiologic one. Such a high proportion of our cases, which is one of the things that we had documented in that molecular epidemiologic study, such a high proportion of the cases was from recent transmission that by turning off the tap, getting people treated right away, we rapidly reduced the emergence of tuberculosis so that treatment became prevention in this case. And this led to really conceptualization of what's needed for public health progress. And I think it's top: technical, operational, and political. You have to have technical rigor, operational excellence, and political support. Those three things are always needed for public health programs. Some of them are needed more in some conditions than others. When it comes to tuberculosis control, for example, it's primarily operational excellence. Tuberculosis control is basically a management problem. You identify all of the patients and you make sure they're effectively treated. If you look at something like tobacco control, that's primarily a political question. Governments around the world have a choice. You can tax tobacco, thereby saving lives, reducing healthcare costs, increasing government revenues, but standing up to the tobacco industry, or you cannot. So any government that doesn't, you know which side of that they're on. Technical rigor is really impressive with certain conditions. I think especially of Haemophilus influenza. When I was in training, it was very common to see people deathly ill from Haemophilus infections. Now we have a fantastic vaccine. And what the data shows is that even when only 30 or 40% of people were vaccinated, herd immunity was so strong, or the R0 so weak with Haemophilus influenza, that the disease virtually disappeared. Epidemics are an existential threat. As you know, COVID has killed probably at this point more than 20 million people around the world from the pandemic, and the effects of the pandemic has cost more than $15 trillion, and it could be worse. Now, the world is rapidly going toward the forget phase of panic and forget. But we can't forget, because so many people have died, so many people continue to suffer from long COVID, and a more contagious and or more lethal virus could emerge, whether it's a new variant that's deadlier than Delta and more infectious than Omicron, or another flu virus, or something else. There's no rule in nature that there can only be one pandemic at a time. Diseases know no borders. Diseases can travel around the world in about 24 to 36 hours. This is the global aviation network. And therefore, truly, the next infectious disease outbreak is just a plane ride away. And a health threat anywhere is a health threat everywhere. I think the main lesson from the pandemic is the need for the 3 R's: a renaissance in public health, robust primary health care, and resilient individuals and communities. In terms of a renaissance in public health, we need to have public health that's aligned across local, city, state, national, and global levels, aligned with political leaders so that we can prioritize evidence-based action and enable multi-sectoral coordination, including economic, educational, and social, regaining or strengthening public trust, and managing where public trust is low, equipped with real-time data to enable the best decisions, and staffed by experienced, practical experts to ensure that when there's more money coming in, it results in more progress. I think from a public health standpoint, you can think of just the level of going from getting good data, analyzing that data well, understanding what the implications of that data are for action, having an open and transparent process to discuss the balance and risks and benefits of the different recommendations, and then implementing effectively. The World Health Organization is essential and necessary. No organization was perfect during COVID, but WHO did pretty well, and it remains essential for data, for guidance, for country support. It provided early warnings in January of 2020 that weren't heeded, but they continue to have problems. It's a United Nations entity, and it works through consensus. Any one of the 194 member states can stop action. That doesn't work for outbreak detection and control. We need WHO, and we need for it to be even stronger. But even if it's stronger, it won't be sufficient. There needs to be substantial new resources, about $5 to $10 billion a year for at least a decade. And again, if you think about top, not only money, but also robust, intensive technical support to build national capacity and operational support. Bill Foege, who I mentioned earlier, was asked what next after the eradication of smallpox, and he said, the eradication of bad management. Improving the public health architecture around the world means money, technical skills, operational skills, governance issues, mechanisms, and scope. These are all important. In this country, we also need a much stronger public health workforce. And I think the single most important thing we can do is to dramatically increase the number of staff that CDC embeds in state, city, and local health departments at all career levels, especially entry level. We increased this when I was at CDC from about 500 to about 1,000. It's fallen back to about 600. I think 3,000, 5,000, 10,000 is the kind of league we need to be in, but it's not going to be easy. Expanding training and early career creates a much more diverse pipeline of workers with expertise and ties. There's a real value of having an aligned vision, not replacing city and state entities, but with incentives to travel back, having many more people at CDC who have real experience working on the front lines. We also need to address funding in this country. And almost 3 years ago now, 3 years in May, we proposed a bipartisan solution called the Health Defense Operations Budget Designation. This gets into a little bit of the budget wonk territory, but it's important. As has been said, you show me your budget, I'll show you your values. Supplemental funding, which is how we deal with emergencies, is only a temporary solution and cannot build sustained programs. Our future health and economic society is best achieved by a permanent budget cap exemption for limited and accountable public health functions, with sustained baseline appropriations for both domestic and global programs. And this would allow Congress and the public to know what's needed and what's being funded. It's not a nice to have, it's a must have. To put it to you simply, we spend between 300 and 500 times more on our military defense than we do on our health defense. But COVID killed more people than all wars killed Americans in the 20th century. Globally, we've suggested a target for early detection and response called 717, that every outbreak, suspected or confirmed, would be identified within 7 days, reported in one, and all essential control measures in place within 7 days. To succeed that, we'll need that top approach. And we'll need to step up readiness. The joint external evaluation provides an important on-paper assessment of how countries are doing. It still has real value. Timeliness metrics like 717 provide a performance improvement framework, and the pilots that we've done over the past year and a half demonstrate that it's feasible for most suspected health threats, that it's useful as a performance improvement metric that identifies bottlenecks and enablers. And many of those bottlenecks are low cost or no cost and can be improved in real time. What we found was, working with 6 countries around the world, is that although the the detection median time was 6 days and 8 days. The mean was much more problematic, and the proportion meeting the target, all 3 targets, was only 27%. And so we have tools that could also be applied in the US for, did we find it in 7 days? Did we report it in a day? Do we have all essential control measures in place within 7 days? And those control measures are deployment of a team, doing the initial characterization, laboratory confirmation, infection prevention, countermeasures or social measures, risk communication and community engagement and coordination. And these last 3 or 4 are in some cases not applicable, but where applicable, they should be done. 717 can be a performance improvement framework, a communication advocacy tool, and a real-time performance management tool. At Resolve to Save Lives, we've also highlighted epidemics that didn't happen, because every day around the world, public health workers are stopping outbreaks. You don't hear about them because they didn't happen. We've documented progress as a way to both recognize what people are doing on the front lines and try to build support for more progress in global public health. The second R is robust primary health care. Primary health care should be central to the healthcare system and focused on improving health, with accountable, high-quality care staff that are well-paid, who are well-paid, with multidisciplinary teams, patient-centered, equipped to manage and prevent infectious diseases, and to strengthen individual, family, and community resilience. Now, in California, you have the benefit of Kaiser Permanente, probably the best healthcare system in this country. But all too often in this country and around the world, primary healthcare is the poor relation. It's not funded, it's not supported. And unless that changes, we will be at risk of preventable illness, injury, disability, and death. When it comes to primary healthcare, I would say begin with hypertension. High blood pressure is the leading risk factor for preventable death worldwide. More people are killed by hypertension than by all infectious diseases combined in a non-COVID year, and more than COVID. In fact, twice as many COVID as killed by COVID in most years in the height of the pandemic. Every 20 millimeter increase in systolic blood pressure, starting at 115/75, doubles vascular mortality at ages 35 to 69. So this is a really important problem to address, and addressing it allows you to strengthen all of the ways we assess and manage primary health care, having a drug and dose specific protocol, having quality assured drugs and equipment, team-based care with nurses, community health workers, pharmacists, social workers, integral and valued members of every team, patient-centered services, systematic monitoring, and continuous program improvement. Epidemic-ready primary health care works on the front lines and is central for detection, for diagnosis, for treatment, and for vaccination. Primary care can improve health in many different ways and improve resilience so people are both less at risk of being disrupted in a pandemic, and also the primary care system can be more resilient and more able to continue core services even in a disaster, whether that's weather or war or pandemic. Third, resilient individuals. We can do this by ending the tobacco epidemic, by protecting people from unhealthy food, promoting healthy physical activity, reducing air and water pollution, reducing harmful alcohol use, and protecting children from addiction to tobacco, alcohol, drugs, and from predatory marketing by junk food companies. Resilient populations are healthier and better able to withstand health threats. COVID has been so deadly partly because so many people were so vulnerable as a result of their poor health status at baseline and lack of social safety nets. Resilience is stronger when environments are structured to support health by making healthy behavior the default choice. You don't depend on someone to go out of their way to be healthy. You make it that if you go with the flow, you'll be healthy. Today in America, if you go with the flow, you'll end up overweight or obese. If you go with the flow, you'll be at great risk of dying from a preventable cancer or heart attack. Environments structured to support health reduce avoidable injury, illness, disability, and death. They help reduce health disparities, and I should say that uncontrolled hypertension is the single leading cause of the lower life expectancy of Black Americans compared to white Americans. So we have an urgent task at hand to improve hypertension control in all people, particularly people who don't have adequate access to healthcare. Community-wide interventions are very effective to improve health. That includes things like high and increasing taxes on tobacco, alcohol, and unhealthy food, reduced contamination of air and water, policies that reduce disparities and inequalities, land use policies that promote physical activity and safe, active transportation, particularly bicycling and walking, and food policies that include healthier eating, including dietary sodium reduction, promotion of low sodium salts, and elimination of artificial trans fat from all food. The trans fat's done in this country. The others, we have a long way to go still. Public health and primary care need to work together. By doing so, they can rebuild trust. They can also strengthen our ability to find and stop outbreaks. And for all of this, communication and community engagement will be critical. CDC literally wrote the book on how to do this, but they were silenced in 2020. Be first, be right, be credible, be empathetic, give people practical, proven things to do to protect themselves and their communities. Misinformation and disinformation can be deadly. Trust can't be surged in an emergency, so it's important to start building those bounds of trust now. Keeping the world safe will require reversing what has been decades of underfunding. To prevent outbreaks, whether natural, accidental, or intentional, detect threats early, to slow or stop spread when and where diseases emerge, and to respond rapidly and effectively. We have to break the cycle of panic and neglect, but there's a second cycle, which is something seen in a lot of the preparedness work around the country and around the world. It's a cycle of planning and more planning. And we find that the 717 tool is a way of breaking that cycle to a find a problem, fix a problem approach. We can't afford another multi-trillion-dollar pandemic, but we can collaborate to greatly reduce the risk of future pandemics. Now, how is this relevant for a local public health entity? First, really important to have stronger local public health, good collaboration between academic medical centers and local public health. What we did in New York City as one of our best cases or best practices was we mapped, there were about 41 different communities within New York City that were linguistically, culturally, geographically, or otherwise isolated from government, from healthcare systems. We mapped each of those communities. What are their information sources? Who are their leaders? And we met with them to listen, to hear what they had to say, to hear what their concerns are, so that when there was an emergency, we knew who to call, they knew who to call, and there was a basis of trust. So stronger public health, stronger primary healthcare systems. That means accountability, empanelment, increased funding, healthcare teams, including community health workers as an integral part of care, and resilient individuals, families, and communities, with progress reducing tobacco, alcohol, drug use, obesity, environmental contamination, and improving nutrition, physical activity, and connectedness, education, work, and support services. I think the bottom line here is that together, even though infectious diseases spread from person to person, in fact, when we work together, we're both healthier and safer. Thank you all very much.
Dr. Frieden, thank you so much for that wonderful presentation. And I particularly appreciated your bridging us back to some of the community level interventions that help to keep us resilient, because the pandemic was really a master class in how these kinds of emerging threats, when you overlay them onto an already problematic situation that so clearly bears out with the CDC maps that all epidemiologists are familiar with, that you just exacerbate the underlying situation. So much appreciated. We are at this point taking questions from around the room. Individuals will be writing their questions on the index cards that have been provided for you, and they will be shared with me, and then I will communicate them over to you. But I thought maybe I'll get us started while the audience engages in that process. So you talked a little bit about the renaissance that's needed in public health and the real need for us to get additional resources, right? Money, tech support, operational support to do this very important work as we think about emerging infectious disease threats. How can we engage industry and private sector to invest in public health infrastructure that's been so chronically underfunded and ill-prepared?
Cheryl, it's a great question. I don't have a great answer. I can tell you what our experience has been in various contexts, that it's important, just as public health or healthcare or individuals or groups are not one thing, business is not one thing, right? So public health is sometimes seen as being not business friendly, but I would take exception to that. I think, sure, public health is not tobacco industry friendly. Public health is not junk food industry friendly. But, you know, if you're a manufacturer, tobacco use is bad for your bottom line. It increases your healthcare costs. It decreases your productivity. What we were able to do at CDC is have a business group on health and encourage them to not so much give money. I think we think of business, they're rich, give us money. That's not actually how they could be most successful, most impactful. Policymakers, whether it's local or state or county or national or global, they listen to business people. So if I go to Congress and say, as the CDC director, we need more money to protect people, they think one more agency director asking me for more money for his agency. When business leaders go to Congress and say, hey, we're worried about a pandemic or an outbreak, and here's something you can do to make us safer so we'll have a better business climate, that is massively more effective. So one way is for responsible business leaders to advocate for public health. In addition, there are obviously some very exciting areas of development, whether it's vaccine development or some of the digital technologies, but where all those have great potential for progress, they rely on government having a clear agenda and role in outlining what industry needs to do. In some ways, it's analogous to what's happened in the global approach to delivering healthcare. It used to be believed that, you know, governments had to do everything, provide the care, fund the care, and many countries are recognizing, you know, if the government can regulate the private sector effectively and guide them, private sector creativity, energy, efficiency can be great. And so it requires really to be very specific about what's needed and how it's going to be used. So not perhaps a fully satisfying answer, but there are a few ideas.
Thank you so much. I want to extend our thinking in that space a little bit to partnerships that we can develop between public health academic entities and agencies that focus on public health. How can we work together better?
That's another great question, Cheryl. I will say that when I was at CDC and when I was at New York City Health Department, we tried to do this and we weren't always successful. And part of the reason is there are very different timeframes. So I think it's quite important to be clear about expectations and timeframes, because you know, when there's just a different clock. I'm just going to turn down the light. I see it's a little bright there. There are different expectations for timeframes. When public health says we need it really soon, that may mean a couple of hours or a day or two, or maybe a week or two. In academic time clock, it may be a next semester or next year, and that's understandable. So it's important to understand each other's perspectives. I think there's a real value in advancing our work on the practical implementation science, understanding what's working, what's not, what's effective, what's not, to really base the kind of research we do on the real world practice. And to the extent that academic institutions can help do that, I think that's enormously helpful.
Thank you so much for that. I want to draw us now back into your, tremendous global health work. And the question here is, given the global nature of pandemics and WHO's role in pandemic response, how do we ensure that a global response is done with equity in mind? How do we make sure that the solutions aren't just benefiting developed or Western nations while leaving developing countries with less optimal control or less adequate access to treatments behind?
It's a great question, and there's no easy answer. Anyone who tells you there's an easy answer is oversimplifying. The kind of vaccine inequity, vaccine nationalism we've seen is ethically indefensible. But it's not enough just to say it's bad. We have to think about what's a solution. In the case of vaccines, distributed manufacturing is very important. In particular, manufacturing in countries that aren't that large, but have large capacity to manufacture more. And so I don't know what's the right answer. But for example, if you want to increase access to vaccines, we've looked hard around the world at the different countries. Korea is really interesting in that regard because it's not that huge of a country and they have massive capacity. So Korea could become a global vaccine hub. And they would quickly make enough for their own population because whatever we say, there's always going to be vaccine nationalism. Every country is going to say, we're going to give it to our voters before we're going to give it to other people. Is that okay? No. Is it a reality? Yes. There was a proposal early in the pandemic to get countries to say, all right, 10% of what we make, we'll make available for high-risk people around the world. That proposal never got very far. Maybe you could get that through, but it's very difficult for a politician to say, we're going to vaccinate people who didn't pay for it, who aren't voting for us before we're going to vaccinate our own folks. So ethically, unacceptable. Realistically, we need to come up with alternatives. But more broadly on the equity question, I think we need to do much more to build national capacity around the world. And that's what we at Resolve to Save Lives do. For example, we have a policy that we don't put any international staff in our national offices. All of our staff are from the country where we work. That we spend a lot of our effort embedding staff in ministries of health and working shoulder to shoulder to build the systems and capacities of the national program. I think this is critically important so that we've also been able to support leaders from several countries in Africa to attend and participate in the global discussions on pandemic treaty and revision of the international health regulations. So you have ways of lifting up the voices of people on the front lines who know what the problems are. This isn't just the right thing to do from an equity lens. It's the best thing to do from a practical lens, because all too often, as you know, Dean Anderson, there are great ideas at the global level, but they're divorced from the local level. So you need to lift up those local voices and address those local challenges.
Yeah. Wow, thank you. Well, you mentioned politicians. So let's take a question around the P of the top framework, which is political will. Given the current extreme political polarization that we're seeing in the U.S., how do we overcome some of this when it relates to science so that we can get sensible, effective policies and mitigate some of the misinformation that's going around?
These are tough questions, good questions to be worked on. But I think for one thing, again, we can decry what's happened. Senator Moynihan used to say, "You are entitled to your own opinion, but not to your own facts." And unfortunately, now people seem to be entitled to both their own opinion and their own facts. How do we put the genie back in the bottle, right? How do we get back to a time when it's recognized that there are common facts? That's not so straightforward. I think some of it means that we in public health need to get better at telling stories, not made-up stories, real stories of real people. One of the things that we did about tobacco control when I was at CDC was run the ads "Tips from Former Smokers." And these were real-life stories of real Americans suffering from tobacco use. And they were unanswerable. So, but they were based on data. They were based on the proof that tobacco causes cancer and heart disease. They were based on the proof that hard-hitting ads work. So it was the use of science. We also not only need to get better at communicating, we need to be faster at communicating. Mark Twain said that a rumor can get halfway around the world before truth puts its boots on. And when we're in public health, in a public position, we need to be really quick about responding to misinformation and disinformation. At the same time, playing whack-a-mole with misinformation isn't going to work. And we urgently need to take a public health approach, take a preventive approach, starting in schools, teaching kids in elementary, junior, middle school, how to look at data, how to understand data, how to understand the sources of validity and not invalid information, how to make people, in essence, more resilient against misinformation.
Yeah, thank you so much for raising the issue of the pipeline, right? It's an opportunity to counteract misinformation and to raise awareness about what is necessary to address these public health emerging threats. So I want to talk a little bit about your perspectives on growing the workforce. So recruitment to the field of infectious diseases was extremely low this past year. What are your thoughts on the driving forces behind that low recruitment to the field, and how does this impact our ability to be prepared?
Money. It's all about money. You know, it's also the case with primary care. A few years ago, I met with a primary care program, and they said, "We've spent the past year soul searching and wondering, how did we fail? Why did we not have success in showing people how exciting primary care is, how rewarding it can be as a specialty, how intellectually challenging it is?" And then we asked our residents why none of them had gone into primary care, and they said, "That's because we can make $70,000 a year more as hospitalists, and it's fewer hours." So I think realistically, the way our society works, there are some people who will do things for other reasons, but ultimately, you're going to have to address the financial differences. And right now, specialty and proceduralists make a lot of money. And so that makes it hard to fill the infectious disease positions. But one of the real win-wins is a team-based approach. Infection control practitioners are a fantastic best buy. Infection control teams can make a huge difference. And just as in team-based care for a clinical problem, team-based care for an infectious disease problem is going to be better. It's going to provide better care at a lower cost, which is more accessible for more people. And I think continuing to think about that will be really important. And just as with primary care, infectious disease is exciting, it's interesting. It's important. It's a fascinating field, and we keep taking over. I say we because I was trained as an infectious disease specialist. We keep taking over more of the world. You know, ulcers and more and more cancers. We're identifying the infectious causes of them. Microbes are not vanquished. they're still a major challenge for us, and that makes it a very satisfying place to work. But we need to make sure that people have, good conditions of work, good respect in their work. When I was an infectious disease fellow, I remember one of the other fellows in my program overheard one doctor saying to another, this chart is really long. Maybe the patient has a fever and we can call the infectious disease fellow to summarize it for us.
Thinking about this team-based approach and the financial aspects of care, I want to just talk a little bit about payers, right? So the question that's coming in here is, really thinking about, you mentioned hypertension as the number one contributor to the number one cause of death, which is, cardiovascular diseases. And how do we avert these excess mortality that we're seeing by thinking about a different approach to insurance? And, the question is really combined in thinking about universal healthcare coverage, but also the role of health insurance in general in that second R that you mentioned, robust primary healthcare. Because as you so beautifully pointed out, chronic conditions are interrelated with infections in this country. And again, we saw it play out over the last 2.5 years.
Right. Big challenge, right? So many years ago, a colleague of mine and I wrote a paper entitled Healthcare as if Health Mattered. Because if you look at how we pay for healthcare, maximizing health, not only is it not the primary driver of how we structure our payment system, it's not even anywhere really on the list. So how can we maximize health? I think the concept of empanelment and capitation related to empanelment is very important. And in an alternate universe, could you imagine taking the successes around the country, the Kaiser Permanentes, the effective community health centers, the most effective components of the Veterans Administration system, there are components that work well and others, and making that our national program? But that requires the basic concept of accountability, that a healthcare team is accountable for the outcomes of the patients under their care, and that they will benefit if the patients are healthier, and they will have a penalty if there is avoidable illness, injury, disability, or death. I think this is a general rule that ultimately the most effective financing system has capitation at the center, along with what I call plus plus. The first plus is more infrastructure payment for places and programs that need particular attention, whether that's rural areas that have limited infrastructure, or the central cities that have limited infrastructure or specific conditions. And the second plus are smart incentives that really do result in better healthcare. And that's not easy. I could go on incentives for a while, but I see you have a lot of cards there. So let me try to take more questions rather than ramble on a few.
Thank you for that. All right, so I'm going to take one that goes back to your days in New York City. And I think there's a budding epidemiologist in the room who wants to know about the mapping of communities in New York City. And, we can see how this would clearly be helpful in an emerging infectious disease threat. But they want to know, did those communities co-design the mapping? How was it received? What's sort of the process that was used there?
So first is to identify them, and that can be done through qualitative and quantitative means. Some ethnic groupings, sub-ethnic groupings, geographic groupings, political groupings. And then it's a question of going out and listening and seeing, how do you work together? What are the concerns? And I'll give you two examples of community outreach. One from one of my mentors, a wonderful man, Sir John Crofton, who discovered how to treat TB. He was working in Edinburgh in the 1950s, and they went out and they asked people, what's your concern? And it was the dampness of their houses. turns out there are a lot of bad things that happen when your house is damp. So people knew what was what, and they helped deal with that. We did something similar when I started as commissioner in New York City. And what we heard loud and clear from many of the communities, Harlem, the South Bronx, Central Brooklyn, was rats. That the pervasiveness of rat infestations in their communities just was devastating, took a toll. It expressed to them that society didn't care about them, that they were living in a place that was blighted. And so we made a little progress. Rats are really hard to control, it turns out. But we focused on it and we involved the community in it. And we did make progress that since has been kind of gone in the wrong direction. But it's a hard problem. Like many things, it requires ongoing effort. But I think the broader question there is, how do you engage communities? How do you co-create programs? Community is not a simple entity. You identify community A. There are probably divisions within that community. There are leaders, there are people who want to be leaders, there are institutions that provide good care, there are institutions that don't provide good care, both within and outside of that community. So it really is a mapping, and it has to do with trying to identify people who can be bridges, who can trust, who can gain the trust or have the trust of the community, and you can have a two-way communication. I think it's really important. We think of communication too often as telling people something. Half of communication, probably 90% of communication, is listening well. You know, you have 2 ears and 1 mouth, so you should be listening more than you're talking.
Well, thank you very much for that very nice bit of advice. I think it's a perfect place to close our conversation with you this afternoon. We know that you have a lot of demands on your time, and so thank you so much for taking the time to be with us today. We wish you continued success in your work. Thank you.
Thank you so much. It's been a pleasure speaking with you all, and best of luck for the rest of your conference. Thank you.
So at this time, we're going to have a break. You'll have time to get ready for our tabletop exercise. That's going to start in about 5 minutes at 2:00, and that'll happen right here, right? Yes. Okay. So right here. So we'll see you back in 5 minutes. Thanks, everyone.
Hello, everyone. So I know we are on a break, but I want to make sure that we have enough time in our next session. So my question is, it's not a question, it's a request. If you are joining us for the tabletop exercise, please fill in the tables towards the front of the room. This means you need to start physically moving now, because you're doing a really good job of being far apart from one another, which is a great public health practice. I'm very proud of you. But we're going to need you to be a little bit closer so that we can play a game together. So please come up and fill in these front tables.
Party starts when a certain dean shows up. That's right, this is the fun section, kids. All right, everybody. Did you bring your game towels? Seems I'm the only one. Next time. It's okay. Letting the last stragglers. All right. So welcome, everybody. My name is Eli Spencer on behalf of Prepare and our new NSF Resilience Center. Welcome to our first real-life serious game. We've been playing these online for some time, and this is the first time we've been in reality. So if you haven't already, can you please either scan the barcode on your table or not the barcode above there? This is a registration. If you're already registered, you don't need to do it. But this is the game registration, critical information. I see actions. If you don't have a cell phone, we can help you. Raise your hand and someone will help. All right, so today we're going to play a serious game. It's going to help us answer the question that Dr. Frieden put up earlier, which is, how are we going to work together? How are we going to play a big game involving every one of us when pandemics are on the line? And we're going to try to show you a little teaser of that today. It's an hour, so you should have maybe your fun hat on and your expectation hat left behind. But the truth is, we really mean this to be inclusive, and it's a way to bring together everyone from longshoremen to clinicians, to teachers, to transport unions. And what we're doing, and we're going to keep the secret sauce secret for now, is these are smart games. They're backed up by computers that are following us, chatbots and AI that are helping us, and everything we do is going to be captured using dynamic systems modeling, which means that we can make this game run in real life, online, and at the end, hopefully, we can give you computable, rigorous policies that help really put together the things we need to answer some of the hard questions we have today. I'm going to get off the stage and move to my role as a FEMA support unit, and I'm going to hand the game tell to our Incident Command Center. Barrett Anderson will be leading today. You should do everything she says, no matter what. No. Let the games begin.
Thank you. Just a note of introduction, I am the COO of Future in Review, which is a conference focused on the future of technology and the global economy, and Strategic News Service, which is the most accurate source of predictive information about the future of technology. We've been working through Future in Review with UCSD for many years, specifically with the Qualcomm Institute, and we love to work with UCSD. So it was a great honor to work with Eli on putting this set of games together. But what we're going to do today is a scenario planning game that helps us anticipate and understand what will go wrong in the next pandemic. Now, this is the second in a series of games that we are designing and running. Most of them are designed to be run virtually. This is our first in-person version. So please bear with us as we pilot this initial game. But the whole idea of this is to help us work together well. So one thing that I think is important to note, when it comes to pandemics, and pandemic response, the hardest thing to deal with is the public, right? It's like the person factor is the thing that public health cannot predict or anticipate. And so to try to emulate that, in our last game, we ran a 3-hour scenario planning game last week where we had different teams play as different groups, frontline community groups. So we had a longshoreman group, we had a group that's focused on hotel workers, hospitality workers, frontline medical workers, and that game actually, as well as an AI and health center group, and a group of chaos agents who came up with weird but realistic things that might actually happen that you would not expect, that could throw your pandemic response efforts into disarray. So all of those have informed the creation of this game that we're playing today. And in fact, they have helped shape the scenario that we are dealing with today. So my question for you is, are you feeling resilient today? I've seen 1, 2, low resiliency, I would say, but I think we can pull that up a little bit. So how many of you all feel that if we today got to do 2020 over again, that we would do a better job than last time? Okay, maybe a quarter, actually, pretty low. And then my next question is, how many of you feel ready for the next global pandemic? How many of you feel like if there was a new global pandemic, you'd be ready? You'd know what to do? No one. We got a quarter of a hand from one person. So I have some bad news for you, which is another novel outbreak is sweeping through San Diego County. And like COVID, this illness starts as an influenza-like illness. We have limited information about the virus in question, how it's transmitted, where it originated, and how to treat it. But unlike COVID, the symptoms of this particular outbreak include sudden bleeding from the eyes. Patients are testing negative for SARS-CoV-2, influenza A, and RSV. The mystery illness first originated or appeared, we don't know where it originated, it first appeared at the southern border amongst detainees. And a CDC epidemiology team has been deployed to look into it. Early reports are showing mostly male patients with high mortality and a particularly rapid rate of spread amongst Caucasian CBP officers. many of whom are now in critical condition. As you might imagine, this has caused some concern amongst the public. Since the COVID-19 pandemic, SDR has developed a cutting-edge regional Return to Thrive initiative for pandemic preparedness and resilience. It contains 3 layers: recognition, response, and recovery, and includes a new resilience center for AI and health, digital and drone surveillance, environmental testing, genome sequencing, and point-of-care testing on both sides of the border. This system is innovative, but is now being put to the test. Your mission today is relatively simple. Acting on behalf of San Diego County, you must create public messaging, a community action plan, and a 100-word press release that explains to the public what actions you will take to diagnose and control the situation. So I want you to look around at the other people sitting at your table with you. These are the humans that you will be working shoulder to shoulder with to develop a cohesive response to this new pandemic. But here's the thing, the people at your table are actually only one half of your team. So because we have fewer people than we anticipated, I'm gonna just break you up, and I'll give you a little bit more information about this shortly, but each team will be composed of 2 tables. If you are a table A, you will be responsible for representing the needs of the urban core of San Diego. So inner city transportation, resource deployment, medical facilities, treating and kind of preventing transmission within the city core. If you are a B table, you will be responsible for advocating for policies that allow the influx of resources and needed supplies into San Diego County. So thinking about things like agriculture, ports, import-export controls, border stance, and what do you want to do to either control or not control the movement of people, right? Migration into and out of the city. Your overarching goal is to minimize transmission and to protect as many people in your that you are representing as possible. But you are also trying to do this in a way that will allow the County of San Diego to maintain its economic and cultural resilience. So with that, I'm gonna just start, because we've gotten a little bit mixed up. This table at the back, can you raise your hand? Yeah, you guys right here. Yep, that's you. Okay, so you're gonna be table 1A. The table in front of you is gonna be table 1B. That means you are the rural group. This reserved table right here, raise your hands with Richard and Heidi. That's table 2A. This will be table 2B right here, just in the front. The table behind you will be table 3A, and the table behind them will be 3B. And that's Eli. Okay. If you are not sitting at one of these tables, please join in. And then over here, I'm going to actually merge these two, this group of 3. Can you join this other table? And you'll be table 4A, so you'll be representing the urban core. And then the table just behind them will be 4B. So the way this is going to work is you have 20 minutes. You will need to work with the other table in your team and negotiate based on the interests of your table. Using the same QR code on your table, you can access the forum where you will need to submit all of your answers. And your job is to come up with a 10-word headline for your immediate public response, a 100-word press release, and a 5-point public action plan. You will need to do this in concert with the other table in your group. So you are acting together as a team with competing and overlapping victory conditions. And you only have 20 minutes. So I'm gonna start things off right now. We also have 2 FEMA representatives. FEMA representatives, can you raise your hand? Eli in the back and Christian right here. And I will also serve as a FEMA liaison. If you have questions, we will be coming around. We can help answer your questions. But to start, one question immediately right here. Yeah, the B group is responsible for all imports and exports into the county of San Diego. So think about agriculture, food. How do you make sure that the city of San Diego has all of the supplies it needs while limiting transmission? No, they're not. No, they're all acting. Yeah. Any questions? All right. Let the games begin. You have 20 minutes. It's 2:20 right now. We will be at 2:40. We will be ringing a bell. I'm setting a timer now. And you need to have submitted your answers to the online form by that point. One important note that I forgot to mention, on the paper in the middle of your table, there's a description of this scenario if you flip it over. I apologize. The other thing, I've heard a couple of you talking about trying to diagnose the disease. That is not an expectation that we have. Your job is to come up with a plan to communicate to the public what you will do to diagnose and control this moving forward. We're not expecting you to figure out, it's not like a clue game where you have to figure out what the disease is. So one last note, I want to make sure that you guys all understand your individual tables are responsible for advocating for a specific group, but the plan that you come up with needs to be in partnership with your other group. So I would highly recommend doing some collaboration early on and frequently to make sure that you are coming up with a cohesive plan that works together. Just to let you know, we are at 2:27, which means we have 13 minutes left to finish your responses, and you need to submit these in parallel and in concert with the other table. So if you are not talking to the other table, by now you should start. Your time is up. Please submit your responses if you have not already. This is your only chance to communicate with the general public for the next 48 hours, and you want to make sure you're giving them good and clear advice about what to do. All right, so I have a little bit of a surprise for you. Two things. One thing, news flash. Hold on, I'm getting a news bulletin that I want to just pull up for you from the outside world. But it sounds like, so as it turns out, there has been a little bit of misinformation in this game. Not on purpose, not on purpose. A lot of misinformation is unpurposeful. But as it turns out, the virus did not emerge north from Mexico. Through contact tracing, it has become clear that the new variant started in the San Diego area, likely originating from imported cases at the airport. The other surprise that I have for you is that there is actually another team that's been playing this game in competition with you online, aided by ChatGPT and an AI agent. So in our report outs, we will be hearing from that team as well as the 4 teams here in the room. We'd ask that you pick a representative, and we'll just start with group number 1 and go through all of those. At the end of that process, you will get to vote on who you think had the best response. And that team will be recognized. We also have a secretive award, the Golden Eagle Award, that we will be administering to a team that we thought had the most creative and inclusive approach to coordination between their 2 tables. So with that, let us start with group number 1.
Where's 1?
Group number 1, yes.
Spokesperson.
Tell us your plan. Read us your headline.
Should we have him come to stage?
Oh yeah, can you pull it up, Christian? No one submitted yet? I hope it's working.
Virus is literally killing us.
Come on up.
Oh, wait. Do you want me over there? You want
Here,
me
come on up here.
Come over there.
Don't take the eagle.
Let's do it. Oh, it's so pretty. Okay. Hi, we're Team 1. Our headline is it we read the headline?
Yeah, read the whole thing.
All right, our headline is San Diego County prepares operational community public health measures to gain emergent. Oh, that doesn't make sense. Health measures. What? Against emerging disease. I'll read it again. San Diego County prepares operational community public health measures against an emerging disease. That's our 10 word. Thank you. All right, this is our 100-word release. As our community is entering this new phase of the possible outbreak, the SD Department of Public Health is taking the necessary measures to ensure that our community remains healthy and safe. We appreciate the public patience and will elucidate the mechanism behind this disease as soon as possible while we continue to monitor, track, and detect new cases. Potential quarantine and isolation measures may be necessary for the public to prevent further transmission. If you present with bleeding from the eyes or flu-like symptoms, please report as soon as possible to your primary care physician. All right, and then our 5-point plan. 5-point plan, here we go. First point, we have case identification, including quantification through blood samples. Next is to determine the pathogenicity of our infectious agent. If determined to be infectious, we have implement the appropriate protocols such as masking, social distancing, quarantine, isolation, and others. And then next is to suspend all non-essential travel across the border because we have identified where our outbreak is. And as we don't know exactly transmission, we're trying to control that. Ongoing community participation and outreach to educate the public. That's our 5th point. We're trying to make sure that all of our public health efforts are not wasted and are continue beyond our efforts as public health practitioners. So that's our 5th point. Thank you all. All right.
All right. Christian, can you pull up team 2? Did you get team 2 submitted? Team 1, thank you very much. That was fantastic. Let's get a round of applause for team 1. And I don't think we got your submissions, so if you can resubmit using the QR code on your table, that would be fantastic. We need these for our future pandemic response efforts. Team 2, can you pull up their response?
Their ambassador should come up here now, right?
Yeah, come on up, team 2, and we'll get your response pulled up.
Dr. Smith.
I don't remember anything, so I submitted it, so hopefully it comes up. I guess I can talk about our 5-point plan. Basically, one is to detect and identify, come up with a case definition, test symptomatic, asymptomatic people, lots of case control studies. Another one is to reduce exposures, try to open up PPE lines, open up the stockpile, get people on board of priorities of who has PPE and who's going to wear a mask in terms of frontline workers, and then essential workers, et cetera. Other times of reducing exposure is to get the public on board for unnecessary congregation, et cetera, needs to be messaged. And including on that would be also educate. So how do we actually do the messaging in real time and really say when we don't know something and when we do know something? And then other one is to stabilize resources, since we were part of also Plan B, is to make sure that we have opening food, money, everything that needs for our program, our city to thrive. Do we have my response? I guess not. The other one is a title was a new outbreak occurs in San Diego. Don't panic. Actually, I don't remember, but maybe that should just be the whole title. It's my favorite book. Yeah, we're in this together. That's actually the last sentence that we had for our 100-word essay. But let's see if we can get that up. Oh, yeah. Is that ours? Oh, that's the first one. No, ours is better. We're. I'm not competitive. We're we are 2B, I guess. 2B or not to be. But maybe if you have 2A, we could bring up 2A. Oh. Nope. I don't think that it was on there. Did it? Okay. I have no idea.
Is it Christian?
I have no idea.
Is it Christian?
I don't know. Christian, is he scrolling? Anyway. Nope. Okay.
All right. Okay, so I apologize for the technical difficulties. Does anyone have their general stuff written down that would be willing to share while we get that fixed? You're going to just bring your computer up? Okay. All right, we're going to come back to group 2. Let's go to group 3. Who is the representative from group 3? We have, okay, great. Come on up.
Okay, so our 10-word press headline is Alert, Outbreak of New Disease in San Diego Border Region. Our 100-word, I actually don't know if it's 100 words, is, as of today, we are aware that there's an outbreak of a new disease at the border. As far as we know, this influenza-like disease is affecting mainly Caucasian CBP officers with predominant symptom of bleeding from the eye that is not responding to existing testing modalities. We do not know the causative agent of this disease or how it is spread, but we have engaged our community partners in public health, industry research, healthcare centers, logistics, and transportation to deploy a comprehensive response. At this time, avoid crowds, especially individuals who may be symptomatic, and contact your nearest healthcare center if you develop any new diseases. And then our 5-point plan. First one is environmental surveillance and contact tracing from health centers and public health departments. Second is identification of disease and treatment led by healthcare centers for case definition and the research community for treatment and research. 3 is equitable distribution of resources that will involve logistics and transportation communities. 4 is communication strategy, specifically how often do we communicate, what will we communicate. And 5, that I don't know if that made it, is defining who is essential personnel and the supportive infrastructure.
All right, awesome. Let's have a round of applause for Team 3. We did find Team 2 submissions, so we are going to go back to them briefly, and then Team 4, you're going to go next, so if you want to prepare yourself.
Somebody do your headline first.
So we did the headline, or new disease outbreaks in San Diego, public health calls for help from public. And then San Diego, this is our 100-word. San Diego is experiencing a new disease outbreak. Little is known about a cause or disease process. It does seem to be infectious, and public health activities are needing, including help from the public. This is a developing situation, and recommendations are expected to change. For now, the public is asked to social distance, mask, and reduce contact with others. Avoid healthcare facilities unless experiencing symptoms. We're all in this together. Cooperation saves lives.
Yay! Good job. Thank you
very much.
So that was 2.
All right, team 4, come on up. And then we will hear from our final AI-assisted team before we vote.
All right. It's going to be vastly different. You've been hacked. It's not accurate. All right, we're group 4. I don't know what you have online. It's not actually what we wrote. So we weren't listening to any of you as we were preparing this paper response. First, the headline we'd like to make sure gets out to every household in San Diego is that San Diego County is closely monitoring and proactively responding to a new outbreak. Oh, I once took some media training. The second thing we'd like to articulate is our 5-point plan, because our 100-line one's going to come straight from the hip. First, we wanted to continue to support our public health infrastructure. And what we talk about is that, generally speaking, it's going to be a lot of different facets. Number one, we're going to continue to focus on contact tracing, isolation, and developing and supporting that through financial resources as well as logistical coordination. We're going to be providing those hotels, helping and aiding transporting potentially sick contacts safely to and from their infection location to a more secure location. We're going to help as the County of San Diego to support our public health infrastructure, transport those laboratory studies, in resource additional advancements in identifying cases, as well as making sure we support our essential healthcare workperson force to be able to respond to the new infections and then anticipate what will likely be a surge in new ones. The second point we'd like to do is proactively identify and intervene on critical supply chain issues. One of the things our group was talking about peripherally is there's going to be a whole lot of issues we discovered in COVID that are going to come up that aren't necessarily directly related to contact tracing and PPE and things like that. And it's discussing things like other critical infrastructure portions, like concerns about food. Remember what it was like to go to the grocery store and runs on food, essentially. So we wanted to proactively monitor and intervene early in what would be supply chain issues at the regional level. We wanted to be able to provide, hopefully with critical stockpiles that we've already established through learning from the last part of this pandemic, to alleviate short-term supply chain issues. As for things like medications, we all work familiar with certain medications like non-steroidal anti-inflammatories, antipyretics for children, formula, et cetera. We also wanted to make sure that we were coordinated in our response with PPE. So that's all under the second point of proactively identifying and intervening on supply chain issues. We wanted to support critical infrastructure. So as people transition, hopefully this infection doesn't get much worse, but if it does, people are going to be going back into isolation. So we'll need to make sure our utilities like water, electricity, internet are functioning and are supported from a regional level to continue to deliver those critical utilities and other critical infrastructure elements. We wanted to develop as a fourth plan a kind of a critical communication platform that could be a trusted source of information from those in the San Diego County. So we wanted to use that as a resource both to collect data from our citizens as well as report and disseminate new information as updates became available. So we were going to explore a technological platform, probably smartphone-based in multiple languages, to be able to be one of those centers of ground truth for San Diego County. And then lastly, we wanted to collaborate extensively with external partners, recognizing that there's a lot of expertise in and out of the county that we need to be able to leverage, not just the CDC teams that are on the ground, other public health agencies in adjacent counties, experts from academia and industry across the globe, and being able to develop an open and bidirectional flow of information early on and develop those relationships as quickly as possible to really leverage a lot of the expertise out there. And I'm going to say for our 100 line, don't panic. It'll be okay. We just did this, and we're still here. Most of us are, at least.
All right. Thank you, Team 4. That was fantastic. So for our last report out, we are going to our virtual team, which has been assisted by ChatGPT in creating their responses. Hello.
I'm back. Thank you very much.
Great.
I'll start with I'm the rep for this group. I'll start with our headline, then our press release, and then get to our points. Our headline is County locking down due to new and dangerous COVID-like infection. The press release reads, the San Diego Department of Public Health is issuing a warning about a new and dangerous COVID-like virus that has recently been identified. The virus, which is not yet named, has been linked to severe respiratory illnesses and death. The symptoms are similar to COVID, but also include bleeding from the eyes. If you experience the latter, please call 911. The virus is highly contagious and is spread through person-to-person contact. We urge everyone to take precautions to protect themselves and others. Avoid close contact with people who are sick. Further updates will be provided as more information becomes available. We are San Diego. We are resilient. Our 5-point plan starts with lockdown, quarantine, isolate. Because the community is very aware of how to respond to COVID, we'll tap into that. And clearly, given the impacts on the infrastructure so far, a lockdown is called for just to bring back some balance on that score. The second point would be to collaborate with Homeland Security. A difference between this virus and COVID is clearly the possibility of bioterrorism or malicious actors. So we should work very close with Homeland Security on this score. The third point would be to shut down the southern border, and we will not make a lot of statements about why we're doing this. We'll just shut it down for the immediate future. The fourth point would be to isolate the region in much the same way that was done in New Zealand and Western Australia, where what we'll do is create a boundary around the San Diego region and more importantly, the extreme southwest corner, where supplies will be brought to the outer boundaries of the region and then distributed by people within the region, but we will restrict travel into the region and out of the region for the immediate future. The last point will be 5, which is collaborate with federal agencies, the CDC, the executive branch, and other groups like that, because this is clearly not a local issue, but unless quickly contained, will be a broad issue for the entire country. Thank you.
All right. Thank you very much. The virtual team coming in strong. All right. So at this point, we are going to vote on our favorite teams. We're going to vote one time for one team. And just as a reminder, Team 1, can you stand briefly? Great. This is Team 1. Team 2, stand briefly. Great. Team 2, okay. Team 3, stand briefly. Thank you very much. And then Team 4, stand briefly over here. All right, so does everyone have in their mind which team they would like to vote for? Which team had the best overall response that made you feel the safest and most taken care of as a citizen of San Diego County? All right, votes for team... We're also voting for the online team. Yeah. So you're between all 5. It's hard to have them stand up. So, but yes, they will be included. So you're voting for Team 1, Team 2, Team 3, Team 4, or Team 5. Group 4 coming in strong.
Which one is 2? Is that 2?
This is 2 right here. Yeah. 1, 2, 3, 4.
We like 2. We're going to give the eagle to this group here.
The middle, the small middle one.
You're going to be separate. I'm going to give the eagle to this pole, or I'm going to say
No, the other
totally
one.
regardless
Yeah,
of that.
the middle. I think the middle one.
Group 4.
All right.
How many responses do we have? 39 responses.
All right. So as those final votes are coming in, there are 2 last things. There's one last thing that we need you to do before we deliver our final awards for this game. The first is there is an exit poll that we kindly ask you to take. And Christian, is that ready to go? We have to wait.
42 votes in.
Has anyone not voted yet?
Okay.
Okay.
Anybody else? Any hangers? You'll get COVID if you don't vote.
All right. So it looks like we have a pretty clear winner, even though we have one outstanding vote that was not able to work technologically. Group 4 coming in with 33% of the vote for their fantastically prepared public statement. I have to say, your experience in public communication really came through in that presentation. Yeah. Communication is important. So the last thing we need you to do before we present the Golden Eagle Award is to fill out this poll. So I think, Christian, it's ready for them now? Okay, cool. So this will help us understand if this game was helpful for you, and it will help us adjust our games for the future to make them more helpful. So please do fill it out.
Absolutely.
Yeah.
You're not checked.
We will not be cross-referencing your ID with your age. Okay, while you guys are doing that, Eli and I are going to huddle about the Golden Eagle Award. All right. I think we have a winner. So this award is being given to the group that did the best job of collaborating across their 2 tables, and who really embraced the spirit of cross-communication and collaboration early on in the game. And with that, I'm going to let Eli announce the winning. This was Group 3.
Group 3.
Woohoo! Which immediately joined tables and started working together right away. So that was why you've been selected. Come on up. Come on up. We're going to take your picture with the Golden Eagle.
You might be small, but you're mighty. Come. You have to take your award.
You don't have to take your mask off if you don't want to.
One of the other people take
Come on up. You're all old? Would you like to?
I
One
will
of you guys
give it
has to hold
here.
the
It's
Golden
heavy
Eagle.
for me, please. Thank you.
Oh, you want me to be handing it to them? Yes. Like I'm shaking. Here.
Yeah. We almost won the World Cup. So French people almost won the World Cup.
Thank
We are fine.
Okay. I assume the Golden Eagle stays behind.
All right. So with that, we are out of time. Thank you so much for your participation today and for bringing your imagination and creativity and cooperation to this game. I think we are all on the same page that this is a very real potential, perhaps not this exact situation, but we hope that this game and going through this exercise has helped prepare you for what kinds of things you might need to think about if we were to experience another outbreak of some kind. This has been a serious game, but we hope it was fun. Thank you very much.
Hello, everybody. The day is not yet done. We are going to, learn a bit more from some of our esteemed speakers. We're just waiting for the last one to join us here. I'm Stephanie Strathy. I'm the Associate Dean of Global Health Sciences, and I also co-direct the Center for Innovative Phage Applications and Therapeutics here at UCSD. And I'm going to just briefly introduce our 4 panelists. And we've got, as from the far left, we have Victor Nazé, who is the director of CHARM and is also a professor in pharmacology and pediatrics. And we have Cheryl Anderson, who is the dean of the Herbert Wertheim School of Public Health, where she's also a professor. We have Dr. Davy Smith, who is the division chief of infectious disease and global public health and is also the director of the Prepare Institute. And we have Chris Longhurst, who is the CMO of UCSD Health. So in the time remaining, we're going to end at 5 to 4. So we have a bit of a shortened time here. We're going to reflect first on what we've learned from the COVID pandemic, not just as global citizens, but what happened here at UCSD that allowed us to respond effectively to this epidemic. What are some of the success stories? And we're going to start with Cheryl first from the public health perspective. Go ahead, Cheryl.
All right. Hello again, everyone. It's good to be here to Is that better? All right. It's really good to be able to reflect on our experience during the early days of the pandemic and beyond. And when you find yourself in a public health emergency, it really does show you what a place is made of. And I'm a teacher of a course here at UC San Diego called Foundations of Public Health. And on the first day of school, I usually tell the students that when public health is going well, no one notices. But when things go wrong is when public health often is on the news. And so we were in early January beginning to see some public health issues in the news. And in February, I gave a job talk announcing my candidacy for dean of the new School of Public Health. And the sort of issue that came up quite often in the interviews that I, was doing was, so what do you think about this thing that's kind of brewing? And I remember saying to the interviewers that, well, it's going to teach us a lot about where we currently are with regards to public health funding and public health infrastructure, even though I really had no idea what exactly we had on our hands. A week later, Nancy Binkin, who is a public health professor of practice here on the campus, asked for a meeting. She came into the office, we're good friends and colleagues, and she says, where's the pandemic preparedness plan for this university? And I said, well, I don't know where that thing lives, but I'll be sure to try and figure that out. She says, we've got something serious on our hands here. And I said, well, tell me more. And, Nancy, who'd been in charge of TB control at CDC in the first phase of her career, an epidemiologist in Italy who had ties still in Italy and was watching what was unfolding in Europe quite closely, said, we are going to be shut down. And we're going to be shut down in about 4 weeks. And we've got to figure out how to get all the students off the campus. And I said, okay, we'll set up a meeting with Chancellor Kosla. So we talked with the chancellor. We said, we've got to get the kids out of here before spring break. And he said, okay. So you fast forward, as Nancy, the soothsayer, predicted, by second week of March, we were in a shutdown, stay-at-home orders by the governor. And it really kicked off here at UC San Diego what I think is a sign of how well we do as content area experts, right? We saw all the expertise coming to bear. We also saw a hallmark of UC San Diego, which is our collaboration. And people were calling from across the health system, from across the various schools in health sciences, across the campus to figure out what we were going to do together to address this pandemic. The public health school, which was new, we were seeing ourselves as having an opportunity to really think about how do we advance things that were happening locally through our San Diego County Department of Public Health in a way that would not have been possible had this new school not been here. And so we convened a public health team. Some of the faculty are here in the room this afternoon, Richard and Nancy and Bob Gunn, who had also been a CDC employee and a San Diego County Department of Public Health employee. And we started to think about what we might do. In the research spaces, we had our research labs here on the campus starting to connect with the epidemiologists on the campus to better understand how, again, that we might be able to start think about this framework of testing, of treatment, and of contact tracing to fully get the pandemic under control. In the background were these really bizarre email exchanges happening between Chris Longhurst and myself for puppy therapy, right? Well, we will go into that later. But there were these conversations happening around what could we do as a university to ensure that the people of UC San Diego, who we knew needed a place to live and learn while we were experiencing this pandemic, had the opportunity to do that. And we knew that that opportunity was not going to be needed at random, right? The students who are going to be in need are going to be the same students whose families have been for, maybe most of their lives experiencing much of the inequities that we see throughout society. And they were going to need a place to live and learn. And so that was really driving our thinking around trying to keep the campus open and a safe place to experience life. So in conjunction with an epidemic modeler, she's, I think, pretty much famous on this campus now, Natasha Martin, and one of the infectious disease doctors from the ID unit, Dr. Chip Scully, we decided to pilot test this thing that later affectionately became Return to Learn. So Chip, Natasha, and myself got on Zoom and we said, what do we need to do to, try to figure out if we can keep the place open? And the chancellor said, gladly, whatever you need, you can have. And we thought, okay, you don't very often get the chancellor to open the purse to say, do what's necessary. And we thought, okay, we're going to start with figuring out if we can get people tested, right? And we set up these testing sites in the middle of the undergraduate housing spaces. And we had to figure out, how to test people, even something as simple as, could you do it indoors? Because what if the swabbing caused the sneezing response, right? Was that going to cause potential transmission? Did we need to have it outside? Could the elements, and this was now April, May, right, where the element's going to hold up in order for us to do this with some level of comfort. And then what would happen if we found something? So thinking about case investigation processes for the people who were identified as being infected, and then the contact tracing elements that would be necessary. Thinking about when you have a congregate living circumstance, which is essentially what a campus is, how does all of the guidance that's happening around the state apply to congregate living like we have it at UC San Diego? And then how do we do it in a way where people understand what's going on so we communicate it well and they feel compelled to participate in the activities at hand? So that was the kind of basic thinking behind Return to Learn. It turned out that the program, the pilot, was reasonably successful, went on to be a multi-unit endeavor across the campus. I honestly think if I were to have to say thank you to every single person involved in the Return to Learn activity, it would be every person on the campus. I mean, it was such a tremendously large and effective way of galvanizing this effort to keep the campus open. But the maybe most significant thing that I think we learned during the early days of the pandemic, and as we were trying to pivot to thinking about keeping people who wanted to live and learn here without infection, was the importance of public health measures. So we had no way to treat, from a medical perspective, COVID-19. We had no vaccine. We were eagerly anticipating, the results of clinical trials, et cetera. But we did know how to use basic measures like physical distancing and, upon diagnosis, isolation, when suspected of infections, quarantining, and thinking about outbreak investigation and things of that sort. And when Natasha Martin and Tom Martin and their team put together the model to show what would have happened between March 2nd and April 27th had there been no public health interventions, and what actually happened, for me, that was everything. You saw that just about 13,000 deaths were averted. Talk about lives that didn't get infected. 13,000 deaths were averted versus the 128 deaths that we saw in San Diego County. So that was a huge impact of all of the efforts that we put together across the county and here on the campus. So I just, want to say that the various things that we did in those early days got better and better over time, which I think, again, is another strength of UC San Diego. We iterate. We started out with something as basic as thinking about a testing site. But then before long, we were drilling robots spaces into each of the residence halls to make sure that we could collect wastewater, right? And we were the first university, to our knowledge, to do that in a large scale way, to monitor what was going on the campus, so that we would be one step ahead of what we would have been otherwise trying to just start with testing. So we check wastewater to surveil for potential infection. I remember the very first time we found it. Do you remember this, Chris? We were on a campus operations group call, and we immediately had to figure out what to do next. And the public health team said, a test sweep. There's no other way. You can't just know that there's, a positive case in a building. We've got to get over there and we've got to bring the test to the dormitories that we suspect the case to be in and make it easy for people to test. Once we have the testing results, now we've got to be able to, interview, investigate, go on and find the contacts, et cetera. So we just got better and better over time at thinking about staying one step ahead of where we were with the infections. Our collaboration with UC San Diego Health System was incredibly important because while on the campus, we have to think about who's living and learning here. Over in the hospital system, they had the best operations around scaling up the ability to test people when it came time for vaccinations, scaling up how to get vaccinations out. And so while we are in our sort of more academics congregate living space thinking about what to do, we were constantly talking with the hospital about what to do as well. So those are just some examples of where I think we did really well, and be happy to take some questions later.
Thanks very much. It was a really impressive operation, and especially as a new leader on campus, for you to rise to the challenge was particularly important, and you did. Davey, could you comment on some of the translational research initiatives that you were involved in and UCSD's School of Medicine was involved in?
Thank you. So one of the big things that when pandemic hit, I was like, oh, this is bad. And what I learned in my time in HIV research is the way to get out of a pandemic is to follow the science and to be very clear about what we can do, what we can't do, and when we can do it. But we needed the infrastructure to be able to continue science. So one of the first things we did was make a test. We didn't have a test. If y'all remember, the CDC was having a problem with their test, and many in this room helped us develop and validate a test that was then used for return to learn and still used today. But one of the big things that we did along those lines was to keep the labs open. Other UCs actually didn't do that. But we had a way to test everyone every single day who was coming into the lab to keep our lab safe so that the science could continue. So that was one. And then the other ones that I was engaged with was I knew we needed a treatment first and a vaccine right along the time. Both of those were very important for HIV. I mean, HIV, we can treat it, right? But we don't have a vaccine for it. And I was thinking the same thing was going to happen with COVID. The vaccine was going to be much further along. So I joined the treatment effort with Operation Warp Speed and Active 2. And we set up the clinical trial spaces around here, both for vaccine and for treatment, to get the monoclonal antibodies that came out first, and the pills, and then the vaccines, which are still going on today in terms of research. And that really did make our community safer.
Great. Thanks very much. I mean, for me, when I look at Active 2 as a model, really, it's not just national, it's global. And, you to be at the helm of it as an adaptive clinical trial where you're simultaneously testing multiple drugs against the best next one. And ruling in a drug is important, but ruling out one too, like hydroxychloroquine and ivermectin.
13 drugs, right? All these were coming in. We had to just get them in and out as fast as possible. And the only way to do that was through an adaptive platform. So we had one platform all across the world. We have 17 countries still operating today to try to find the next generation of drugs, because now we know monoclonal antibodies don't work. And even with HIV, remember the first antiretrovirals worked great. That was the miracle I saw in my life, that people with HIV walked out of the hospital because of those first generation of drugs. But they were horrible. They caused all sorts of problems. And now we have once a day pills and injectables, et cetera. And that's really where we need to head with this pandemic.
Absolutely. Thank you. And now, Chris, can you talk from the UCSD health perspective? I mean, I think we all learned that Petco Park isn't just for baseball anymore.
Yeah, that's right. In fact, I went to REMAC for a women's basketball game last week, and I had PTSD. In fact, this entire symposium is giving me PTSD. But it's humbling to be on this panel with some amazing scientific leaders. I do want to say there were no emails. Our private conversations are all encrypted. They never happened. They're not discoverable. So there were lots of lessons learned, and particularly successes. I think we're all extraordinarily proud of the campus partnership around Return to Learn. The health system's been really, really proud about the Exposure Notification System partnership, and Dr. Malakinejad's here from CDPH, and that was something we launched in the fall of 2020 and continue to partner on with Dr. Garfin and Dr. Aronoff Spencer's leadership. We are particularly proud of a partnership with the city, the county, and the San Diego Padres on the state's first vaccine superstation, one of the first in the country, and all the lessons learned that we had around that. But as Patty liked to say, it was a shot in the arm of morale as well as vaccine. But I wanted to highlight maybe just one lesson learned that was particularly positive, and one that was something we could learn from the next time. So on the positive side, Cheryl, you mentioned Dr. Nancy Benkin. And Nancy was a pediatrician who retired from the CDC. And as we started sending out analytics to our entire health sciences team, all 20,000 employees would get our daily readiness dashboard. Nancy was quietly putting all of the data into a spreadsheet to evaluate vaccine effectiveness using real-world data. And I'll never forget, we started vaccinating in January, obviously, at scale. And Nancy got in touch with me in maybe March and said, this is what I'm learning. And we published some data about the real-world effectiveness matching the trials. And then it was during the summertime when Delta hit of 2021 that the CDC was saying breakthrough infections are rare. And yet our dashboard every day was showing us employees and patients and students who had been fully vaccinated and were getting COVID. In fact, they accounted for the majority of people getting COVID. And Dr. Benkin and I had some vigorous conversations and crunched some data, and we got her some support. And in fact, we, of course, published some of the first data in the country showing that the real-world effectiveness of the vaccine had dropped substantially with the Delta variant. And I'll never forget that there was a private audience with with CDC leadership prior to the decision on the booster. And remember that this was the first time ever that the CDC had not taken the Advisory Committee on Immunization Practices recommendations and had actually made an exception and said healthcare workers should get a booster shot as well. And we felt somewhat confident after our private conversations that our local data had contributed to that national decision. And to me, what that really highlighted was the importance of really rigorously and diligently learning from our own data on an ongoing basis. And I think that's something that we across UC San Diego did extraordinarily well, was to take a humble approach to a disease we didn't know much about. And as Davey said, to constantly learn. And so that's something that we're continuing to try to scale and expand as truly a high reliable learning health system at UC San Diego. So very proud of that and lots of lessons learned. In terms of perhaps something we do differently next time, I will say that I feel very strongly that the visitor restrictions in the hospital were detrimental. And there was a period of time when we knew very little about the disease early in the pandemic when it made sense. And unfortunately, people suffered and even died in the hospital without loved ones present. But it took far too long to lift those restrictions. And, that's something that I think we can partner with our regulatory partners on next time around to make sure that we fully recognize, the benefits from a safety and compassion, empathy standpoint of having those loved ones in the hospital setting that, probably lasted longer than it needed to.
Thank you very much. And Victor, can you talk about what the basic scientists were doing? Because they were not sitting idly by. I mean, we had some very interesting people involved in, like Kim Prather doing aerosol research, and others that were studying spike protein and different variants, and how quickly COVID was evolving as a virus. So what's your perspective on what were some of UCSD's most important contributions?
Yeah, no, I think a lot was learned from the basic science perspective, and I think UCSD made major contributions. And as a researcher, I participated also just as a citizen in the original Pfizer mRNA vaccine trial, and entering it as a physician scientist, I was honestly thinking this vaccine has very little chance of having side effects, but I was also not that, I didn't have very high expectations that it was going to be a very potent protective agent, because mRNA vaccines hadn't been proven, but basic scientists had kept pushing this forward. you'll learn, I think, within the next couple of years in a Nobel Prize speech or two about how persisting in something you believe in that may have broad applications. When these first trial results came out against the original virus with 90% protection, people could begin to envision really impactful vaccination campaigns that no doubt saved many millions of lives in our country and worldwide. And that was inspirational. I think the mechanisms that were in place through Return to Learn extended to the laboratories, and scientists felt confident that we were on an aggressive pathway to have lab participation, 25% occupancy, 50% occupancy, but we were always ahead of the curve there. And I think was really amazed at how many PIs working at the top of their game in different areas shifted major parts of their program and their laboratory to this response. A microbiome scientist, a basic RNA biologist, a geneticist coming together to bring us the Excite laboratories, which helped us meet the testing capabilities that made Return to Learn and the wastewater sampling possible. And basic researchers looking at their expertise and asking how might it apply to COVID. And we have a lot of very exciting basic research that was published on the T-cell correlates of protection, the structural aspects of the viral capsid that led to antibody and vaccine design, potential basic mechanisms on cell entry, that there are cofactors like the heparin sulfate on the cells or cholesterol that could be potential targets for future therapy to limit the severity, the viral replication and transmission, and reduce the inflammation in the disease. And many of these collaborations started with an epidemiologist identifying certain factors and then basic researchers in the lab. We developed organoid technologies, basically mini lungs in the laboratory, mini brains for the CNS effects of this virus, and rapidly upscaled our BSL-3 capabilities to be working with live virus. And I think all the basic scientists that contributed to that can be very proud. You can also look at the funding that the university has garnered, and despite a lot of scientists staying at home, they found ways to be creative, to think of new solutions, to write grants, and now we're close to 1.5 billion in extramural funding, and one of the premier institutions in the nation and the world, with a lot of people also thinking about pandemic science and infectious disease therapeutics and preventative measures and diagnostics as a future part of their portfolio. So
great. Thank you very much. So now I'm going to ask the panelists what they would want to do differently. What have we learned from our successes and even our failures, not just here at UCSD, but as humans, as as members of society? What would we want to do differently? And Cheryl, when I ask you this question, I think that you bring a lot of experience because you have a social justice and health equity lens. And I'm somebody who works with some of the most marginalized populations in San Diego County, people who are homeless and people who inject drugs. And right now, I can tell you that only 1/3 have had their primary series for COVID vaccine. And so even despite the fact that we have really great vaccine coverage in San Diego County, there are disparities. So what do you think we could do differently next time?
Yeah. So I think one of the key strategies should be sort of that foundational meet people where they are approach. And we had some very important things happening, the opportunity to be tested, but then what did we see? Testing was not available to all of us, right? We had when the vaccine effort, rolled out in Petco Park, we thought you couldn't get better than Petco Park. I mean, like, you can't find a more accessible location than Petco Park, but it didn't cut it, right? We needed to actually go into communities and make things available, meeting people where they are. And so I think starting out doing more of that would have been really helpful. It also, to me, is completely linked to our communication strategy. And, when I was training in public health, we had risk communication as sort of an elective that you might have taken if you, gotten around to it in like your last year kind of thing. And we've seen risk communication become just more core and central to how we train now. And I think that on this campus, we did a really great job with communication, but I think we could have done even better to get some of those key messages out. The other interesting thing is that when we think about, was the public ready, or could the public have been readier? I believe this before the pandemic, and I believe it even more now, that you shouldn't graduate from college without a public health 101 class. And I think had we all had a public health 101 class, the public would have been starting in a much different place in terms of hearing some of these very key messages about averting death, right? We wouldn't have to wait to see bodies piling up before we were called to action.
Yeah, that's an excellent point, and it's something that we could do to revise our curriculum. Davey, what does pandemic preparedness mean to you looking ahead, given your experience leading Active 2 and being, really on the forefront of the development of some of these new treatment regimens?
Sure. Yeah, thank you. I want to tag on to Cheryl for just one. I want to answer part of her question because it was me. I was thinking, what would I have done differently? The biggest thing was on communication as well. I did not talk to the press because I did not like talking to the press. I do not like talking to the press because they're not nice oftentimes, but it was something that needed to happen. And I wish I had more education around it, and I did that. And I think that was super important. So that's something we could have done better. That's something I could have done better. Okay, so how are we going to be prepared in the future? Some big ones is that we knew COVID was out there. SARS-CoV-2, 99% of the virus was already detected in a bat 10, 15 years before. I could have made a monoclonal antibody to it 10 years ago. Same thing goes for all the coronaviruses that are about to jump over. Same thing for other viruses of pandemic potential or antimicrobial resistance. We can be prepared. We have a lot of the technology now to do so. What is lacking? Money, will, that's what's lacking. And that's where I would really push it to where we could be prepared for the next time.
Great. Now, Chris, you knew I was coming for you. And I'm really happy as somebody who, watched my husband in the hospital for 9 months, not with COVID, but with a superbug. I know how important it was to his resilience to have me and other loved ones nearby. So thank you for addressing that. But looking ahead to the next inevitable pandemic, how would you ensure that the healthcare workers at UCSD Health don't fall prey to burnout?
Don't what?
To burnout.
Burnout.
That's my Canadian accent. Out and about. Burnout.
Well, maybe I'll answer Cheryl's question too. No, I will answer your question. I do want to tag on actually one thing on Cheryl's point, which is that I will never forget Wednesday, January 6th, when the county supervisors called and said, we'd like to partner to do a major vaccine, effort. And can you open on Monday? And we huddled and got our teams really engaged and galvanized. And we did. We opened on Monday. And the only way we could have done that was with online scheduling. And of course, the unintended side effect of that was to widen the digital health equity gap. And within a few weeks, we saw in our data that, in fact, we were vaccinating people from well-to-do areas that weren't necessarily high risk, but had the means to travel, et cetera. And so I think there's a much greater awareness of how we can partner, as Cheryl said, with community benefits organizations to go meet people where they are. Our mobile vaccine unit has been just absolutely astounding. And with some generous philanthropic support, literally righted that gap. So definitely a lesson learned for us next time around. I plan to be retired when the next pandemic hits. So I will not be worrying about it. But, frankly, burnout is an issue independent of the pandemic. And, one of the side effects, unfortunately, has been the Great Resignation, particularly around nursing staff. And the staff who didn't quit, who are still with us, are feeling incredibly burned out. They haven't had those breaks. We also have major challenges with our physicians and other clinicians, and we've got, I think, a wide variety of efforts to battle burnout, across the health system. Some of these are going to pay off more than others. And just like the pandemic, we're going to learn as we go on what works the best and where we need to shift our resources.
Thank you very much. Well, Victor, you get the opportunity for the last word before we hear from Davey, our director. And you and I both know that there is another pandemic that we're already facing, a silent pandemic. So what can you tell the audience that they should be aware of and how to prepare for it?
Yes, we're talking about the pandemic, long in the making and accelerating of antibiotic resistance, which Davey has wisely made a component in Prepare, and which on a research basis, the Collaborative to Halt Antibiotic Resistant Microbes with 80 different faculty members participating from a research and educational perspective also are involved in. Over 1 million people are dying globally from antibiotic-resistant infections on a trajectory by 2050 to increase tenfold, and then, maybe match cancer as a cause of human mortality. And it's kind of humbling for most areas of medicine. If you talked about Parkinson's disease or a particular type of cancer, there would be optimism that 10 years from now we would have more options. But really, for many of the leading bacteria, people worry that we're losing options, and the lack of creativity and maybe some aspects of the financial model make a lot of disincentive for antibiotic research, or difficult for academics and companies to survive in this area. But UCSD, I think, is trying to be visionary. We want to think outside the box. We want to use science to broaden the definition of antibiotics. Nothing is a better example of that than the Phage Therapy Center, the first in North America, that was developed by Stephanie and Chip Schooley, and based on the innovative clinical science that helped save Stephanie's husband, Tom Patterson's life from an otherwise untreatable antibiotic-resistant pathogen. And many other investigators here are looking at the immune system as a partner to try to harness the same types of innovation that led to dramatic improvements in cancer therapy, to bring those to the treatment of acute infectious disease. Our nanoengineers are coming up with very creative ways for drug delivery and toxin inhibition. And we're looking at vaccines against the superbugs, and vaccines to decrease the antibiotic resistant burden. And also the clinicians themselves, how to limit antibiotic exposure in the hospitals, and how to teach people that antibiotics have critical efficacy when used right for the specific bacterial infection, but also do damage to your microbiome. And the great Center for Microbiome Innovation we have here is also looking at the resiliency of the microbiome and probiotics as effective therapies. So I think it's a collective action problem, like global warming or pandemic preparedness in general. People have to look beyond their immediate self-interest or their immediate assessment of their own tolerance of risk, and think about what it means to society, about societies that did better in controlling the virus, did better economically, even though they're short-term smart decisions that may require some mitigation, some isolation, some restriction of activity. And hopefully we can open it up to antibiotic resistance too. Just we can't only focus on the hurricanes, these giant events like the pandemic, but also on the global warming, the long-term issues that make hurricanes more likely, and antibiotic resistance is like that. The outcome of any pandemic that sends a lot of people to the hospital is going to be worse if we can't control antibiotic resistance.
Yes, thank you very much for mentioning that. Obviously, antimicrobial resistance is a topic near and dear to my heart and my family's heart. But I also think that the story of how my husband was saved with phage therapy, which are viruses that have naturally evolved to attack bacteria that are sourced directly from the environment, is an innovation story. And UCSD and UCSD Health really played a key role in this, because I've been told many times since my husband was cured that other universities would not have allowed an investigational therapy like this to be tried on a patient, even if the patient was dying, or to cut through the red tape in time to make it happen. So I feel really honored to be here at UC San Diego. My husband is even happier. He takes out the trash every time I ask him now. But also, I mean, I think that looking forward, we need to have the lessons from COVID and how COVID interacts with other outbreaks and epidemics. For example, just antimicrobial resistance alone has worsened 15% increase in bloodstream infections associated with hospital infections since COVID began. So this is something that I want to be on everybody's radar. I also want to thank Congressman Peters' office for attending today, because risk communication isn't just among the general public. We also need to educate our policymakers. And in fact, Chip Schooley, my husband and I are going to Congress next week to speak to the Congressional Subcommittee on Energy and Commerce about our experience. And so it's another way that we can share what's going on at UCSD and how it's saving other lives around the world. So with that, I will thank all of you, and I'm going to ask Davey Smith to come up with a few closing words. Thanks very much.
Okay, thanks everybody. Actually, you know what? Thank you for coming. We are better prepared just by having done this. And hopefully you had fun today. Hopefully you learned something. Hopefully you can take this forward, and hopefully you can join us in our next efforts to be prepared. I also wanted to really thank the staff, and Steele and Liz and Eli and Brian and the whole group. Just really putting this together is just really an amazing event, and they were prepared. So it was great. I'm a virologist. Things evolve, things change, new pandemics are coming. The best thing that I learned being at UCSD, and I've been here for a long time. I was an intern here, a resident here, infectious disease fellow. And now the best job ever, being head of infectious diseases and global public health through a pandemic. Crazy time. But UCSD had that vision, and it was just really nice to be working in a place that said, okay, this is a problem and we need to fix it. And I'm hoping that we carry that forward, because I think we will. I think we have the right stuff to use our vision, to use our minds, to use our work to actually make the world a safer place. So, and our voice, that's what I got to remember, because you got to talk to the press. But anyway, and y'all, I like talking to you better than the press, but thank you for coming today, and hope to see you all soon.